Good morning, everyone. Good morning, everyone. It's my privilege to welcome you today to our webinar, first in our webinar series on addressing workforce issues through a learning health system. My name is Adrian McKenzie, and it's my pleasure to be your moderator for today's session. I think we'll, as we clear out the room here, I'll introduce myself a little further. I'm the session to be put on in partnership with our colleagues at the Pan American Health Organization, and I am a co-investigator with the WHO PAHO Collaborating Center on Health Workforce Planning and Research that's based here in Nova Scotia at Dalhousie University, and I'm also the Director of Research here at Nova Scotia Health. And before I introduce some of our speakers for opening remarks, I'd like to acknowledge that both Dalhousie and Nova Scotia Health are located in Mi'kma'ki, which is the ancestral and unceded territory of the Mi'kmaq people, and that we are all treaty people. These acknowledgements are part of how we show respect for and honor our shared treaty commitments with the Mi'kmaq people. Our agenda for this morning begins with opening remarks from Dr. Puertas and Dr. Tom Murphy, and then we will transition into our panel, which features Dr. Sapali, Dr. Martin Meisner, and Cindy MacQuarrie, and they will each speak for about 10 minutes. At that point, we'll open the floor for a Q&A session, and Gail will close things off with some remarks from her end. So at this point, it's my pleasure to introduce, pardon me, I neglected to provide the overview of the objectives for today's session. So the intent is that by the end of the session, participants will be able to identify and describe key principles of a learning health system and what that means from policy to practice. That second, they will be able to describe how creating a learning health system can help address health workforce planning issues, including retention, recruitment, deployment, and so on. They'll be able to describe how a learning health system can mobilize the collaborative practice for health workers from education to transition to practice. And lastly, that they'll be able to describe the critical research and or evaluation that are still required on the go forward. And with that, it's my pleasure to introduce Dr. Benjamin Puertas, who is going to provide some opening remarks. Dr. Puertas is the advisor for HRH for the Caribbean based in Barbados. And prior to this role, Dr. Puertas served as PAHO Health Systems and Service Advisor in Honduras and as the sub-regional advisor on HRH in Central America and the Dominican Republic, as well as the regional director of health in Malawi, Mozambique with the African Refugee Committee and Médecins Sans Frontières, and as an advisor to the ministerial office in Ecuador, leading its health reform process. Benjamin, over to you. Take it away.
Thank you very much. I was looking at my photograph and hoping that I still look like that one in this video. Well, thank you very much, Adrian. It's indeed a pleasure to bring you remarks as we launch the webinar on learning health systems and the impact on health workforce. Allow me to also express my enthusiasm to collaborate once again with Dalhousie University, an institution that continues to maintain valued partnership with the Pan American Health Organization and is always at the helm of groundbreaking and socially innovative research. PAHO and Dalhousie University have a history of working together in areas of common interest, mainly policy development, planning and forecasting, capacity building and training of human resources for health. Since October 2021, Dalhousie University has been an active PAHO WHO collaborating center on health workforce planning and research, providing technical input to PAHO on HRH policies, strategies, and implementation plans for Caribbean countries. About a year ago, CARICOM launched the Human Resources for Health Action Task Force for the Caribbean. This effort came as a mandate by the Council for Human and Social Development, COSOT, during the 39th meeting on November 2020. PAHO acts as secretariat for this initiative, providing technical cooperation to the HRH Action Task Force. I often boast that we continue to engage the expertise of some of the most brilliant minds in human resources for health. The task force comprises official delegates from ministries of health of 15 countries and 2 territories in the sub-region, as well as representatives from regional and international organizations such as CARFA, the regional nursing body, WHO, and academic institutions such as the University of West Indies, University of Guyana, and Dalhousie University. Dalhousie was invited to the HRH Action Task Force as an expert organization, and I'm certain that we are all honored to collaborate with the institution once again. Last year, the HRH Action Task Force partnered with PAHO to develop 2 policy briefs in support of HRH policy development in the Caribbean. The first one on intervention to strengthen HRH in responding to COVID-19 and other emerging pandemics in the Caribbean. And the second one on addressing COVID-19 vaccine hesitancy among healthcare workers in the Caribbean. In October 2021, during the 41st COSOT, ministers of health approved the policies and urged member states to adopt and adapt the policy actions contained in the policy briefs. Currently, the HRH Action Task Force is working assiduously to implement these policy actions, including one related to the provision of appropriate and up-to-date training on HRH priorities. This important event is aligned with the needs of HRH training in the Caribbean, and PAHO welcomes the opportunity to become a part of it. I am confident that the webinar on learning health systems and the impact on health workforce will provide needed training in areas considered a priority to PAHO and to most countries in the region. The Pan American Health Organization, and in particular the Sub-Regional Program Office, will continue collaborating with Dalhousie University to improve human resources for health in the Caribbean region. So thank you very much to all of you. Thank you to the presenters, to Dalhousie for organizing this important webinar, and I'm very happy to participate on it. Thank you very much.
Benjamin. And Gail, this brings us over to you, and it's my pleasure next to introduce Dr. Gail Talbot-Murphy, who is our Vice President of Research, Innovation, and Discovery, as well as our Chief Nurse Executive here at Nova Scotia Health. Gail is an internationally recognized expert in population needs-based approaches to health system strengthening and workforce planning, as well as in evaluation and research. Gail is a champion of innovation in healthcare, and she leads teams and partners to seek creative solutions and agile processes to address the many challenges facing our province's health system and to deliver the best care possible for improved outcomes of our population. Gail has been an expert advisor on health workforce to the World and Pan American Health Organization since 2005 and is director of our WHO PAHO Collaborating Center on Health Workforce Planning and Research here at Dalhousie. Gail, over to you.
Thank you. And over thanking Benjamin, but also I hope my picture is not like that picture, which I think was still Benjamin. But now we're moved over. So thank you so much, Adrian, and thank you to everybody. I know that we've got a number of people participating with us today. And so I'd like to say good morning and good afternoon and also good evening for some of you. And would like to thank Benjamin from the bottom of my heart for joining us today, but also bringing some remarks from PAHO as well as the WHO. And as a collaborating center who was designated first in 2008, so 3 designations. In our 4th designation, I have, as the director of this collaborating center, have learned so much from our partners, many of you who are on today, PAHO as well as the WHO, and I've had the privilege of learning from and working with many countries in the Caribbean, as well as in Africa and Tanzania and Zambia in particular, and in addition in Brazil over the years. And so the work that we do in terms of our mandate are really 3 things. We're all about building capacity, and that is building global capacity and sharing with each other, but really working at the country level to build that local capacity, which is incredibly hard. And, you know, starting with the health needs of populations and figuring out the care that they need, to the delivery of care and then the workforce to actually deliver that care, formal and informally, has been really important to all of us globally. And we've been really pleased to be part of this. And we, over the years, have had, I think I need to recognize that our key stakeholders, many of you I know and who are participating today, but many others who aren't here. And so we've had, the center overall has had about 25 projects on health system strengthening and workforce planning in 12 Caribbean and 2 African countries, as well as 10 Canadian projects and 4 global initiatives. So it's been our privilege for sure. I don't need to tell all of us, but I will set the stage that global workforce strategy is important to all of us. And COVID-19 has definitely shone the light on that for very many reasons. And pushing forward, strengthening HRH roadmap for human resources for universal health is incredibly important. And we've been working with Benjamin and others to actually move this forward, to address those challenges that many countries, many of you are facing. And we have learned so much as we take on this task, and we're pleased to continue to do this work. So this is our first of what we hope many webinar series where we will focus on issues. We want to engage you in many of these webinars as we move forward. And we see this more as an opportunity to start to share some of our experiences, our lessons learned, and to learn from each other as we transition what it is that we're doing, with the focus on equity, diversity, as well as inclusiveness in our health workforce, team delivered care that wraps around patients and families and organizations, communities based on their needs. And so those are just a few things that we're talking about. So over to the session. I know that we're focusing today on learning health systems. And I must say that people are talking a lot about learning health systems, and we see ourselves as the learning health system. And so we've got some people who are going to share some of their stories and their perspective, and we're really interested in what they have to say in terms of the success in Nova Scotia Health and in our partnerships in Nova Scotia. But we also want to hear from you. So some of the questions that you may have might include things like, what does it mean to actually be a learning health system? And we may be clear on that, we may not be. But how do we do some accomplishing and this transition to a learning health system, giving some personal experience around this, but most importantly, also drawing from you some of your experiences and some of your questions. And I think also you're wondering how learning health systems actually impact the health workforce around retention, recruitment, and planning for. And we're really excited to talk about some of these things in terms of education and transition to practice. So Adrian, back over to you to get on with the people who really have more to say than what I need to be saying. So thanks.
Thank you, Gail. And I just would echo and build on your comments that I know the panelists are keen and ready to speak, and I know they're perhaps even more keen to hear the questions and insights that their presentations prompt from the participants on the call today, so we can, as you say, learn more from each other. So it's next my pleasure to introduce our first guest speaker, Dr. Tara Sampali, who is our Senior Scientific Director at Nova Scotia Health. Tara, in her approach, effectively blends research with practice, bringing the novel concept of embedded research into our healthcare system here in Nova Scotia. Tara leads our implementation science team at Nova Scotia Health and works closely with across the research innovation discovery portfolio to bring proof of concept initiatives to fruition. Her research interests include chronic disease management and multimorbidities, integrated models of care, knowledge management, and application of innovative IT solutions in healthcare. Her team has pioneered the concept of rapid reviews that have played a central role in informing Nova Scotia's health system response to COVID-19. And Tara, I'll bring it over to you.
Thank you so much, Adrian. And I know you're controlling our slides, so I'll request you. Thank you so much. And I just want to say good morning, good afternoon, good evening. And I'd really like to thank the Collaborating Center for hosting this important session and learning series. And I'm so delighted to be part of this, to share our strategy, but also our lessons learned. And really, it's all about sharing and learning. And some early learnings from Nova Scotia and some early successes as it relates to engaging our system and the workforce in the learning health system strategy. So to start with a little bit about myself and Nova Scotia Health, I work as a Senior Scientific Director in the Research, Innovation and Discovery portfolio at Nova Scotia Health. And for many of you who may already know, Nova Scotia Health is the provincial health authority in Nova Scotia. It is the largest employer in the province, diverse employees, physicians, nurses, healthcare professionals, volunteers working across the province in over 45 different facilities. And these include hospitals, community programs, primary healthcare services, and they are in various settings, urban and rural across the province. And so for Nova Scotia Health and the province, this is a very unique opportunity, and you'll have seen the leadership and the focus on the innovation, the test and try. And for learning health system, this is really critical, the notion of test and try as we understand together. And, we are a unique size in the province, really well positioned to do something like this. Although our resource and infrastructure may be small, but we're really definitely growing and learning. And some of the challenges and considerations, though, are not unique to us. In the context of learning health system, it is what we are seeing in the evidence globally. So I will start in a way, and I know my colleagues who will kind of add to this will share and kind of complete the picture. So I'm really eager to get started. But before I get into the details about the work in Nova Scotia, I'd like to look at some of those basic questions that kind of Gail was positioning about the learning health system. So Adrian, if you don't mind advancing to the next slide. So I want to tell, and I think, Dr. Gail Tolman-Murphy, in your opening comments, you said learning health system is becoming the most referenced, discussed, presented topic in the recent years. It's also probably the most challenging concept to wrap our heads around, saying, what does it really mean to have even a strategy or an implementation plan? And especially, we talk about learning health system, and the system really needs to engage in a learning health system. And this is really critical. And there are so many definitions that are out there. And definitely the most widely referenced one is from the Institute of Medicine. And in just looking at the definition, you'll see the complex interplay of evidence and data, key stakeholders and partnerships, a culture of continuous quality improvement, and really thinking about the real-time impacts and outcomes. And in the literature, you'll also see when learning health systems are referenced, it's about the emphasis on the principles becoming a foundational enabler for the transformation of the system. And that's really key. It's not just about, here's your learning health system, here we are. It's just ingrained in the way we do things. And there are key processes that have been identified. So you think about, how does it start? You're planning, you're implementing, evidence and data informs that. And now you're implementing, and ongoing, you need to learn in real time. Is it going in the right direction? Are we doing it well? And so we need rapid evaluation surrounding it. And then we need to know, how do we sustain it? Is it really sustainable? Are we doing what components of it? So we need to really inform the system and inform the scale and spread of all of these. So this is really key. And, for us, if all of these are important, they make so much sense. So what is it about becoming a learning health system and some of those considerations that are really important? So Adrian, if you don't mind going to the next slide. And again, what I'm saying here will ring true of wherever we are in whatever systems, trying to think about the opportunities and the considerations. So in many of the things, learning health system is all about partnerships. And this really requires our ability to understand each other in a very meaningful way. And this includes the partnerships we have with our patients and communities. And, as we think about those partnerships that are critical, be it our academic partners, be it our industry partners, and all other partnerships we need, we really need to align ourselves as it relates to each other's mandates, strategic priorities, while we also figure out the space where we work together. And that's really key. And there's also a need for intentional involvement. So, we talk about collaboration, we talk about partnerships, but they don't just naturally happen. And in the context of learning health system, they have to be very intentional and they have to be very meaningful. And they need to go beyond the usual ways in which we are used to collaborating. So we say, well, here's a research funding opportunity, lo and behold, here's a letter of support and something may happen. And also we cannot wait for funding cycles because they need to really happen and move at the pace at which we need to move. And, it's really about, as I said, the engagement of the system, and the workforce and everybody that's in the system. So the rapid timelines, we're all used to that, has to be happening today and every day. And it has to be driven by data, by evidence. And we need to create those information and transformations and learnings that really need to support it. Evidence also highlights some of the critical enablers are having that structure and the governance. The time to really invest in these roles that are like embedded, and we know these are embedded scientists, and we know CIHR has such an emphasis on the health system impact fellow positions, and they show up in many ways. But really, when people talk about embedded, you have to understand that you have to be integrated into the system. The system has to build the comfort in the presence, and really people need to see, and busy teams and providers and patients and families need to see the presence. And that's really key, and a key critical consideration. And I will say a lot of the literature right now in learning health system focuses from the academic perspective. And this is really key and important. But also, I think there's a significant gap, as we see right now, in what does it mean for the system to engage in the learning health system? And I think that's really critical. So let's look at that a little bit. So what does it mean for the system to engage in a learning health system? So Adrian, if you don't mind going to the next slide, please. So we know that the system is complex, dynamic, the relationships, the players, the pace is very complex. And the boundaries of what a system is also very fluid. It changes with the needs of the population, and the partnerships really build based on those needs. So at any given time, the notion of a system is constantly evolving. And that's always going to be a grand challenge for building a strategy for a learning health system. And I feel that there's a real need to, despite all of those challenges, to really understand what is the system's role in a learning health system. And much of the, considerations from a system perspective, small as they are, they all focus on the critical enablers. So as we think about the system engagement, it's really critical that we engage the providers and teams. Despite being busy, they need to engage in the notion of a learning health system. Everybody has to play a part. And then you think about our patients and communities. What do they understand? We know that they want the information, evidence to be used in every day in the way that they receive care. But it's also critical that they become part of the planning and build a strategy, which we co-design, and that's really important. And I think some of our work in Nova Scotia has really built around that notion of, those enablers, but some challenges and considerations on how the system has to engage in real time. And what does it mean? So I'd like to talk a little bit about what we have in Nova Scotia and what are we learning and what does it look like. So Adrian, if you don't mind going to the next slide. So in Nova Scotia, as I mentioned, it's a key enabler, and we are recognizing, and I think nationally in Canada, we are being recognized for the way our partnerships are really strong. And this is across many different sectors, and that is really key. And for us, this not only includes the academic partners, like I said, it's a community partnerships, it's our foundations, it's our industry partners. And I must say, I have worked in the health system for a number of years in many different roles. And I'm really truly grateful for the vision and leadership that Dr. Gail Tomlin-Murphy has brought in her role as the VP Research Innovation Discovery and as the Chief Nurse Executive in the province. And even pre-pandemic, she had her vision. There was a blueprint of what this needs to look like. And, Adrian mentioned about the implementation science, and that's really key. And there was already a recognition and a strategy that was developing, even in the early 2020s, when we're thinking about what will the strategy really look like? How do we engage the system, but the key partners in developing something that will become Nova Scotia Health's journey in becoming a learning health system. And these strategies and initiatives have to be front-facing to the system and the needs and the infrastructure and the roles. It's also about the workforce. So in looking at learning health system, it's not only about being innovative and meeting the needs, it's about really having the people capacity in the workforce strategies. So I know that my colleagues will focus on some of those examples, but I'll really focus on what does it mean to integrate that evidence and the infrastructure to support. So just before the pandemic, the notion of a network of scholars is really keeping this open and flexible environment where people really want to learn and understand the system. But it really needs a very intentional strategy to onboard, your PhD level scientists, your masters, undergraduates, a health system impact fellow program from CHR, and in a way that it's flexible and adaptable to those learning competencies that people need, and how we might engage them in a way that also meets the priorities of the system. So there was already a strategy of what this should look like, but also from our learnings to date, we had done some rapid reviews where, Adrian mentioned, it's about being very nimble and adaptable to that local context. And this often is a challenge when you think about the funding cycles. They're not always catered to that local contextual question and the evidence development that needs to happen around that. So sometimes people will say, well, that's something for you guys to do. You should just build that evidence yourself. And that's true. So these rapid reviews are very much about these local contextual questions. So we had done a couple of those, and they're very much driven by the planners and people who need to implement. And the way even those rapid reviews are tailored in the final presentation is very much about, I need to apply it today, and what will it take for me to take it from this evidence to my planning, to developing an implementation, and then really surround that with all other things that are required, the rapid evaluation, support for implementation. So we had done that, and developing all of those key learnings. And of course, the pandemic happened, and not unlike every other system and jurisdiction that's out there, it dramatically changed our understanding of why we need the evidence, why we need the rapid evaluation, how do we know it's making an impact, and universally the importance of rapid learning from rapidly emerging evidence by that uncertainty of we don't know all we need to know, but we're going to learn in real time, became a normal way of behavior. And that's really our experience. That was our experience in Nova Scotia. And lo and behold, here we have a strategy that was just evolving, and all of a sudden it propelled us into this massive space of people start to engage around all of those COVID-related questions. And then it became the way of doing business. So I'm very thrilled when people say, oh my God, let's wait for that rapid review before we do a planning session. And that to me is a key milestone to achieve for a health system that engages across. So if I were to say between March 2020 and now, we've done over 350 rapid reviews, and we continue to do. And they were initially very COVID-focused questions. We did many things like learning not only about the immediate needs of vaccine efficacy and everything, but also the long COVID. What does it really mean? Do we know if we are developing a program that can be informed by evidence, but also supported to be implemented and evaluated, to really everything? So we go from HR-related questions all the way to somebody saying, I need to implement a new service or a program. What is the evidence around it? Will it work in a rural community? Will it really have the impact it needs to? And then really taking that all the way through to the implementation science initiatives, where we surround it by providing that kind of an infrastructure for the implementation team, which is usually as big as 50 key stakeholders across the province, and they include patient advisors who are asking some critical questions. They hit a barrier, they want to know, how can I change this? And then we surround that, bringing the evidence, saying, how have different jurisdictions done this? What can we learn from that? How can we move this along? And then create the evaluation that is so comprehensive, because this is about scaling it to other communities. So we want to know if community A experiences and the evaluation is showing, will that be adaptable in a different community? So I'm pleased to say that we are in a position where we have now surrounded it with very high impactful project, from virtual care initiatives. We have our virtual care Nova Scotia, which is impacting across primary care, chronic disease management, emergency departments, to our collaborative types of teams, where we are really looking at optimization of scopes and roles, and continue to look at the pandemic impacts, looking at nursing workforce, looking at not only the impact of the COVID, but also from long-standing issues that really need to take us to a strategy and implementation of key initiatives. And our strategy has been showcased by the McMaster Forum, where they did an evidence review, and really as an emerging leading practice in what we have done. And the CHR Health System Impact Fellowships, we are probably the biggest consumer of all the fellows. And there is a publication coming which is talking about showcasing Nova Scotia as moving in the right direction, learning along the way. And I just want to say that there's much more. And Adrian, if you go to the next slide, it's just about saying where to from here. We need to acknowledge the system in learning health system. We need to acknowledge the partnerships that need to really get strong. We need to acknowledge that will always be fluid, will always be dynamic, it will always be challenging, but it's really about wrapping around the strategy needs to adapt and make its way, and we need to learn along the way. So this conversation is very exciting, and I really thank you for your time. And Adrian, over back to you.
Thanks very much, Tara. I think the piece I particularly like about you've got here is the testimonial from the patient partner, and I think there's no better test than of an initiative like this, of that it's visible and impactful to the patients that are involved, and that's why we're all here at the end of the day. So thank you. I'm next pleased to introduce Dr. Ruth Martin Meisner, our next speaker. Ruth is a professor and director at the School of Nursing and Assistant Dean of Research and the Faculty of Health at Dalhousie University, where she's taught for more than 30 years. Ruth is an affiliate scientist with Nova Scotia Health and the Maritime Spore Support Unit, and is co-director of the Canadian Centre for Advanced Practice Nursing Research at McMaster University. She's known for her contributions to the advancement of nurse practitioners in Canada for more than 2 decades. And the focus of her research is evaluation of the implementation and outcomes of the nurse practitioner role and team-based models of care in primary and long-term care. The results of her research have been used to inform policy related to nurse practitioner scope of practice, education, regulation, and deployment across sectors and populations. Ruth, over to you.
Thank you so much, Adrian. And I just wanted to start by saying what a pleasure it is to be here and to have this conversation with every one of you who's online today. And I wanted to take the opportunity to thank Dr. Gail Tomlin-Murphy for the invitation for me to join this panel and to just tell her publicly how proud we are at the School of Nursing at Dalhousie for her many years as an academic within this school, but now in this incredible role she has with VP, by being VP of Innovation and Research, and also the chief nurse for our province. So very proud of having the Hupaho Center situated in the School of Nursing for its 3rd designation. So I'll get you to go to the next slide, the next one. That's just a title. So I'm really focusing on the education component of a learning health system. And really thinking mostly about post-secondary, so university education. There are probably other considerations for other types of education, but what I'm talking about today is really university education, and particularly for education for healthcare professionals who then will participate in learning health systems. And so starting with just taking a look at what was out there, because I've never looked in the literature to actually see what's out there about education in learning health systems. And I found there isn't a lot, although, you know, when I kept digging, there's more there than what initially sort of appears on your first blush when doing a search. There's even less literature about learning health systems and primary care, and that's sort of where our systems are going. Primary care is the foundation of learning health systems around the world. So there's some opportunity there to really explore more what the role of education is and what the opportunities are in primary care. I did, interestingly enough, like I said, you keep digging, there is actually a toolkit out there already that has been produced by Madison School of Medicine. So there's actually probably more work going on than what we're aware of. So Adrian, I'll get you to go to the next slide. So I'm going to just share a couple of examples that I hope will illustrate some of these concepts that Tara's been talking about. And one is the development of an interprofessional academic family practice. So we have, as I'm sure most large universities have, a family medicine practice, like a clinic, a family medicine clinic that offers patient care and is also a site for medical learning. And to some extent over the years, it has started to become interprofessional in that there is a pharmacist, there's pharmacist learning, occupational therapy, some nursing, not much yet, but we're getting there. And I'm probably forgetting. So we talk about an interprofessional academic family practice that largely focused on medical education. Recently, well, it's not that recent, unfortunately, our province, like so many others, has struggled to keep up with meeting the needs for primary care. There are a lot of people in our province who do not have access to primary care, let alone be attached to a primary care provider. So that is really the population health problem that brought the partners that I'm going to talk about today, which you can see on the last bullet, together to really try to look at what can we do together to solve this problem. So it's the Nova Scotia Health, of course, Gail and Tara and Cindy, all those folks that are here today have been very involved in this from the Nova Scotia Health side, driving a lot of it really. Our government, and then the two faculties, the faculties of medicine and health at Dalhousie University. And health comprises 11 different disciplines, different health professional disciplines. And nursing is one of them. So together, our goal was and is to, I'm not sure, there's a mistake here in this slide, but the goal is to recruit and retain providers, not only NPs, in communities without a primary care provider, to increase access for all of these people who do not have a primary care provider. I think that this is, somehow these slides have gotten a bit mixed up. I apologize. I'm just going to go with, because I think what's happened is some of the bullets have gotten mixed up with the titles.
Okay. Do you want me to move to the next one then, Ruth?
Okay. Yeah, so apologies, but the bullets are actually belong to the previous slide. So I don't know, there's something's gone amiss. So I'm just going to speak from my own notes. But the goal of the interprofessional academic family practice is to increase access to primary care and to increase the panel size that the providers have. So in terms of the learning health system, which puts a lot of emphasis on using data to help make decisions on an everyday kind of basis as well as a long-term kind of basis. So we, in our discussions as we were considering how to work together and what we might like to do in terms of the academic family practice, we're able to access data that most of our partners had around the number and types of patients that were currently using the academic family practice. Not perfect data, but nevertheless, by learning together about what the data systems are that we were using and being able to find a way to use that data to help inform what we were doing. So I guess my point is, data doesn't have to be perfect in order to be useful. You have to, and then the other approach that we're using to try to help inform the way forward is value stream mapping, which is an industrial engineering approach to gathering data about the components of the work that people actually do. And so the way that will help us is by being able to identify sort of, in some ways, sort of the practice patterns of each healthcare provider in the family practice center. And then to really analyze, are people functioning to their full scope of practice? Should we be doing some rearranging of responsibilities and roles? But you can't really do that without data. And so the value stream mapping is really helping us see what actually is happening on a day-to-day, on the ground interface with patient care. So there are tremendous, I could go on and on about this, but there are tremendous opportunities to further enhance this idea that Tara spoke about in terms of learning labs. And it's not that the academic family practice centers haven't been doing some of this over the years, they have, but it can be so much more than what we've done in the past. And the opportunity and encouragement for people, whatever their roles are, whether they're practitioners, they're students, they're researchers, they're educators, to test and try different approaches to providing care as an interprofessional team, and not to be afraid to do that. So that is, I think, the opportunity that is before us. We're just in very beginning stages of this. There's all kinds of assets that education has to bring to a venture like this, not the least of which is students at all levels of learning. I think I'll go to the next example.
Speaking of students, yeah.
The next example is the Nurse Practitioner Expansion and Incentive Program. This is, again, a partnership between Nova Scotia Health, the provincial government, and Dalhousie School of Nursing. And the goal here is to recruit and retain NPs into communities that do not have primary care. So they're typically rural, but not always, but mostly rural communities that it's been hard to fill, or there's lots of turnover in the primary care provider role for those populations. And so we've been working together to, on the education side, of course, the education of these nurse practitioners is one piece, but the incentive program really is part of a learning is part of a learning venture together of how to do that, and quite novel, I think, in Canada, based on the emails and inquiries we've had from across the country. So it uses employer and education data. Again, none of our data is perfect, but we are improving it in order to track admissions progression and in the field. And I'll go to the last slide, just on a few reflections. I think one of the papers that really impressed me was by Kevin Groombach, who's from the US, but very compelling paper, just around sort of reminding us what our focus should be, and that learning and research and education really needs to focus on learning and knowledge translation, and always our eyes on the goal, which is to. I thought that was a pretty powerful message. And then he also addresses, as there's, like I said, there's very few papers that do this. And this was actually a commentary, I think, but he talks about, some practicalities about how we can start to teach some concepts early in students' education, medical students, nursing students, about that in order to improve patient care, alignment with what their expertise would be as beginning students versus with QI initiatives as more senior students. I really taken with the notion of testing, trying, and scaling up innovations that work. And that whole cycle is, I think, a really important take-home message. As I've said, data is not perfect, but we do need to pay attention to that to constantly improve our data systems. But I think just as importantly is learning how to better use the data that we have. And I'll just finish by saying what everyone here on this webinar already knows, and that is that collaboration is really key to all of this work. And I'll stop there, Adrian.
Thanks very much, Ruth. I think the data piece, I think, is key, and I really particularly liked your point around when we often don't make full use of the data that we do have. We can't hide behind the excuse of, oh, we don't have the data anymore. So I think we'll go next to Cindy, our final panelist this afternoon. Cindy MacQuarrie is the Senior Director of Interprofessional Practice and Learning here at Nova Scotia Health, and is a PhD candidate in the Faculty of Nursing at the University of Alberta. And in 3 more days, she'll be Dr. MacQuarrie, no longer the PhD candidate. And since 2012, Cindy has initiated, led, and managed organizational change that's been required to foster interprofessional practice and education at Nova Scotia Health. And in her current role as Senior Director of Interprofessional Practice and Learning, she shares expertise on interprofessional practice, education, and scope of practice matters. And as a PhD candidate in nursing, her research focuses on entry-level nurse experiences with interprofessional collaboration in Nova Scotia during the COVID-19 pandemic. Well, Cindy, over to you.
Great. So thank you so very much for the invitation to be with all of you today. I am so excited to be able to share with you the perspectives from Nova Scotia Health in relation to advancing interprofessional practice and learning. So maybe Adrian, if you can just pull up the slides there. So just to kind of set the stage, I have to maybe present a little bit of my passion for this topic, and we'll ask Adrian to try to keep me on time today, but look really forward to hearing questions from the audience and colleagues online as we continue to learn with, from, and about each other. And I have to say, from my perspective, this work really gets me up in the morning, sets my feet on the ground to be able to look at the practice problems that exist in everyday practice and how it is that we can create solutions with people for everyday problems. The Interprofessional Practice and Learning Team is a provincial team that is situated within Nova Scotia Health, but we certainly have a very broad mandate, meaning that we rely very strongly on the partnerships that we have with many key stakeholders within Nova Scotia as well as outside of the province. So from my perspective, the Interprofessional Practice and Learning Team plays a key role, as I've suggested, to advance collaborative person-centered care. And we certainly do that through 4 main mandates. And I wanted to really shine a light on the learning health system aspects that have been so eloquently shared by my colleagues online today, and how it is that we utilize a framework to really situate our thinking in our team as we enter into these practice conundrums every day. So certainly I just want to say that the elements of person-centered care and how it is that the partnerships show up in our work with patients, families, and communities, the integral nature of team-based care, and how it is that we look at the elements of the team-based designs, looking at the scope of practice or employment of our healthcare providers, regulated and unregulated, so that we can certainly look at opportunities for improvement, removal of barriers around regulation legislation, as well as policy directions. Around the evidence-informed practice piece, we really drive and define professional practice standards within the organization, but also play key roles in influencing those standards outside of the organization and elsewhere. And a really important pillar, and I'm so happy that I have Ruth with us today, because certainly we work very, very closely on learning, but want to share that our role is more uniquely in the post-licensure arms of this learning piece, where we focus on the learning, the continuing professional development, as well as the recognition that this is absolutely exhilarated through the academic and government partnerships that we hold. And the importance of, Dr. Sampali's presentation really speaks to the notion of data and how important our evidence is for us to have that knowledge and understanding, bringing that knowledge and understanding to the practice interface, and then also learning from practice and those more close to practice to really continue these cycles of rapid cycles of learning, and that our outcomes really are very broad. But at the end of the day, looking at specifically the population health needs in Nova Scotia, the patient family experiences, how it is that the providers and teams are taking up those experiences, and as well, how it is that we understand the evidence in care and the interface of practice. So next slide, please, Adrian. So I wanted to really provide 2 key examples to illuminate how it is that we approach this within Nova Scotia Health. But certainly I will stick on these 2 examples, but certainly can share more broad examples as well for those that may be more curious about how this may live out in acute care. So specifically in a critical care environment, emergency care examples as well. But for today, certainly wanted to narrow in on 2 key examples. So in both of those examples, you will notice that we certainly have put proposed solutions in place, but that we are continually learning on an ongoing basis. And to be honest, we're making mistakes all the time. But I think the commitment is that we always want to do the best that we can and bring the right people around the table to create those solutions together. And we haven't refined it, but certainly we continue to be committed to have a learning health system approach in all the work that we do. So the one example that I think is a really proud moment for our team in Nova Scotia is really the implementation of the registered nursing authorized prescribing strategy. It was noted, and as well in Ruth's presentation, how in Nova Scotia we are challenged around access to primary care. So alongside of the great example she provided, another example that was implemented in Nova Scotia was that in 2018, 2019, there was a real desire to advance the scope of practice of registered nurses. Other jurisdictions have done this marvelously, and we certainly learned from them in our processes, policies, standards, and practice as we continue to implement this in Nova Scotia. So the solution of optimizing the role of registered nurses happened in designated areas of the province. And we were especially concerned about areas that were having challenges through our data accessing care to primary care providers. So in partnership, we applied a learning health system approach. We partnered with government, our academic partners, our Nova Scotia College of Nursing. We worked and continued to tirelessly work with our labor and union colleagues on this endeavor in our province, as well as work very closely with healthcare providers, patients and families, and our operational colleagues as we learn with, from, and about each other. As far as the outcome is concerned, I'm very proud to say that we actually have, for the first time in the province, a registered nurse authorized prescribers working in the interface of care in primary care, and as well we have them in select emergency care areas across the province. What we are learning, some emerging findings through our evaluations, is that the registered nurse prescribers actually have greater job satisfaction. One registered nurse, actually we've retained her because we've supported her with this education endeavor. She was ready for retirement, but because she's had this opportunity, she's actually going to be staying in the workforce for a longer period of time. As well, we've noticed that there's increase in interprofessional collaboration with the team, with physicians and nurse practitioners and the registered nurse authorized prescribers. We have noticed increased access to care, and so much that the areas that they have the RN authorized prescribers integrated into the team are actually going to support further RNs to be able to have this advanced knowledge. And last but not least, I think the team productivity piece is something that I have significant curiosity around. And as well, we are noticing that the team productivity is shifting and that there is greater access to care overall in those communities. So Adrian, I might get you to shift over. So Tara has talked a little bit about, what is happening in Nova Scotia, and this slide is a little busy, but certainly wanted to pull out some really great examples here. So there are, like Tara suggested, a number of facilities in our province. We have over 24,000 employees within Nova Scotia Health for a population of about 1 million. The reason why I wanted to share this example is that student and learner placement approaches in clinical education is really the backbone of our future workforce. And certainly in Nova Scotia, we are working every day to do the very best we can to foster learning closer to home. So the conundrum that we face, the practice problem we face, is really that there was, and at certain points, I think from my perspective, still a lack of standardization on learning placement approaches. And there continues to be, and we've been in this work from a provincial lens for at least 5 years, inequity and a lack of access to clinical learning within Nova Scotia Health. So we have stood up a provincial student learner placement office as well as approach. I'm very proud to say that through the work of the team, and I want to recognize the backbone of any great team is the people that do the work every day, and I'm here sharing their work. So I just want to recognize that they work on an ongoing basis to maintain 92 different partnerships with university colleges and other learning institutions across the country. In the last year, even through the COVID experiences that we've all been facing, there were 39 different roles, disciplines that we've been working with, from nursing to clinical psychology to occupational therapy to any kind of assisted role, unregulated role. And as a result of the ongoing commitment for us to be able to have foster the learning closer to home, we know that learners are getting clinical experiences in more diverse settings across the province. So not just in urban centers or not just in the tertiary or higher acuity areas, that they are having more opportunities in more rural and remote locations. I'm very proud to say the team has placed over 6,500 learners in our organization over the last year. And a large majority of those are coming from the nursing profession, meaning learners coming from practical nursing, our bachelor programs, as well as nurse practitioners programs. And other disciplines. So I just wanted to share that as a really great example of the types of placements and the velocity of work that certainly comes from this commitment. And at the end of the day, I just want to stress here that we use this data to be able to make improvements, and our partners, we work very closely in the province to understand from our academic partners what barriers exist for them, so that we can ensure that we're working to remove those barriers and learning from them and their experiences as well as the experiences of our learners. We want to foster, champion learning, discovery, and transition to practice for future generations of healthcare providers. So thank you for that, Adrian. And I just have a couple closing key considerations that will help to kind of maybe frame up some of the key points to share with those online today. As I've mentioned, our team continues to learn with, from, and about each other, and as well our partners. It is an ongoing commitment. We look very closely around the population needs, and we are very thoughtful about the design of our curriculum and programs to illuminate those needs as identified. We use multiple strategies throughout the province, and I can certainly speak to a few of those, but we have a very robust interprofessional simulation program that we are certainly building upon to help to support and bring practice supports closer to home for healthcare providers. We have partners, and without our partners, we would not be able to do the work that we do every day with government, our regulators, service providers, and academic partners to design for system needs. And we are measuring impact in real time. And I can't stress how both amazing that is, but also how very challenging that can be to ensure that we have the rapid response teams and learning cycles happening on an ongoing basis. And it's really crucial to stress how technology enhances that ability. And findings informing our workforce planning, but also the developmental pieces. I just want to stress that the key part of this developmental piece from my perspective is really around how it is that we identify this from a professional perspective, but also the interprofessional perspective, and how it is that we want to stress the interprofessional learning and practice pieces. And the test and try piece, which really came up strongly with the two former presentations, I want to share this here because I feel that the test and try notion is so important. especially in the interface of care, and how it is that we have an ability to be able to set a provincial strategy, but also have local level implementation. And that test and try notion is really important in how it is that we engage our practitioners and care, our patients and families close to home, the types of strategies that we use, but also the degree of relationships that we have with those people and how that can be fostered to commit to the end goal. And I just want to say that that is a really important part of how it is that we work with our people to engage, collaborate, and partner. So thank you. I believe that's the end of my presentation.
Cindy,
Thank you all very much.
Thank you, Cindy. Before we go to Adrian, I'd like to also acknowledge Dr. Annette Elliott-Rose, who is on as a participant today. And we work incredibly closely with Annette, who is the VP of Clinical Services and Chief Nurse Exec at the Isaac Walton Killam Healthcare Organization, which is Women and Children's. And she also is associated with the WHO PAHO Collaborating Center, as I do note there are some other participants as well. So Annette and the IWK have been central to all of our partnerships as it relates to what we've described today on learning health systems, and in particular around the work on the RN prescribing, which I note that there are some comments in the chat about some interest in that. And so back over to you, Adrian. I just wanted to add to that. I know people who are presenting and looking at the slides can't see the chats. And so now we're in a position where I think we can get moving. Thank you.
Right. Thank you, Gail. And Annette, lovely to see you on. And thank you to Janet too. I want to note for the stats we have, if I read correctly, over a dozen countries represented here for the session today among the registrants. So really looking forward to hearing response and perspectives. I see there's already been some dialogue in the chat. And we do have a question already. You can please use the Q&A box, or you can use the chat. We'll keep an eye on both for your questions. And for the panelists, our first question is from Brian Condren. Do you have any general advice for those getting started in integrating a learning health system approach into an organization's operations? More specifically, do you have any recommendations regarding how to evaluate the development of a learning health system approach? For example, examples or useful models or framework. He's going to have to come back later on, but we'll check the recording. Thanks in advance for Brian.
I can definitely try to get started, and I'm
Thanks,
sure everybody will contribute. And I think, Brian, great to get the question from you. And I think it's such an important question in terms of the evaluation. As I had mentioned in my talk, even the notion of a learning health system is so elusive, it's so conceptual, and the importance of being able to evaluate. And some of our learnings is that we have to have confidence in our ability to describe how any initiative, anything we're testing does bring the principles of a learning health system. And I think that's really critical as we start to examine then the impact of such initiatives. So we have some examples that you'll have heard, and there are many more that are developing. But in all of our approach, it's been to really evaluate the principles as a starting point. Do we have the partnerships? Have we engaged the people? Is the system participating in providing the feedback? And really mapping out the steps of a learning health system is equally important. And then to evaluate the impact in doing things in that way, and what will that inform as something like that scales, but also scales to other initiatives as an approach. So I would say the emphasis should be on, are we thinking about the design and the principles of the learning health system in any initiative before we go to the evaluation? And then maybe we'll develop a blueprint for the evaluation and the plan and the approach. But that's my starting point to kind of raise for people.
Thanks, Tara. I couldn't agree more. It's setting the design parameters is you can't really do the evaluation without having those in place anyway. So I think I agree that's foundational. Cindy, Ruth, are there any considerations you would like to add to Tara's response to Brian's question?
Yeah, so I also want to recognize the importance of in Nova Scotia, the research, innovation, and discovery team as well, because I believe, from my perspective, there is an element of that certainly is the infrastructure on the operational side. So I think from my view, I can speak to, the interprofessional practice and learning experience and how it is that our team has certainly grown leaps and bounds, as we've strengthened our partnerships with, Dr. Terry Simpali, Dr. Talma Murphy online, and as well with Dr. Martin Meisner, that those partnerships and having that infrastructure has been a real key enabler for the work to happen, like I said, at a provincial level, but also bringing it alive at the local level. So I just wanted to stress, and through that, I think it really speaks to the ability for the practice to best inform the provincial pieces of that data drive and knowledge.
Thank you, Cindy. Ruth, anything to add on that piece, or we'll, if not, we'll go to our next question.
I think we can go to our next question.
Sure. Okay. Our second question is from Jennifer Andel, and Jennifer asks, as the learning health system is set up, is there any particular mechanism or approach that can be used to bring the key partners together around the concept? And I think all of you have spoken to partnerships, so this is a very topical question. Thank you, Jennifer.
It's okay, I can definitely start, because I think it goes back to, and I think such a great question again, it's really important in recognizing the partners, who are the partners. And to me, I keep emphasizing, and I think there's still evidence in the literature that has to emerge around it. It's the level of engagement of the system is really critical. And we see this, and there are many things that are evolving, and in our understanding of the importance of data in real time, the evidence in real time, but to really bring the partners together. And as I mentioned about the patients and families, our communities, our providers and teams, and the partners we need to really enable that infrastructure that we need to support. It is really helping people see, for instance, for partners to really engage, and I definitely will speak to the health system partners, the ability to see the quick wins. The value proposition is really critical in this. And we need to, sometimes we do some great work and not often do we share kind of the impact and the impact on care and where the value exists. So I think it is important in the engagement strategy that we really also acknowledge how we are sharing those findings, the impact, and how it might be then it'll generate more conversations. I also feel that we don't always go the distance. Sometimes we share the findings and we don't draw the perspectives on the findings. That is equally important in the notion of a learning health system. So that would be my response to that, and a great question.
Thanks, Terry. I agree on that. Having a clear value proposition so folks could see what the benefit of participating and partnering is, and then following through with an evaluation or other measurement structure, and sharing those findings back so people can see exactly what that story, the impact has been. Cindy, Ruth, anything you'd like to add? Yeah, Ruth, go ahead.
Yeah, I'll just add that I think rather than having the focus on the learning health system, the focus, for me anyway, what's been helpful, this may not work for everybody or every group, but for me, what's been helpful is having the focus on what we're trying to achieve. How is this what we're trying? Why are we coming together? And what are we trying to achieve with patient care, patient outcomes, and keeping that as the focus, and then building the learning health system ideas around that. But keeping that, always coming back to that, I think has been helpful in a lot of our initiatives. So I would say that in like a lot of what we've done we haven't actually formally talked about us being a learning health system, but that's what we're doing. We've got the components, and I think through guidance from Tara and others, the learning system concepts are there, but they're not the main focus. So you're learning how to do it by doing it, but focused on addressing a problem, a challenge.
And if I may just add to that, Ruth, it's also about being creative about the partnerships.
Yeah.
Like and to your point, what are you trying to do and who do you need? Because not often will the partners be the same. And we really have to get very creative and comfortable depending on where we are trying to develop this. And it may not always look the same, to really think outside the box of your typical partners and who need to be at the table. I think that's also important.
Mhm. Yeah, I think the only thing I want to add there is in relation to the ideas of collaborative leadership and collaborative leaders. And I feel from my perspective that there are, those relationships. So not only that individuals that are partners are coming into the space collaboratively and showing up collaboratively, that there is the relationship, and the strength of the relationship will foster the ability for us to have really critical conversations. And as a result of that, we can, find ways to communicate around the particular concern, come to a common ground, but also have this element of evaluation that's happening in real time. So I just wanted to really share that, in Nova Scotia, we that notion of collaborative leadership really shows up really nicely.
Good point.
Thank you all. Our next question is from Dr. Puertas, and it's for all the panelists. I know Tara's already keen to respond. What were the main challenges and opportunities to the learning health system efforts during the COVID-19 response?
I'm happy to go if it's okay. That's a great question. And that's been such an exciting aspect of such a challenging portion of all. I know we've all experienced the same during the pandemic. Has been really the uncertainty of what we know or what we don't know. And things have emerged in real time. They've really shown kind of the vulnerability of, or being vulnerable to the position of not knowing, and developing on the evidence, not only from what's in the published literature, and we know it was far and few, and they were emerging in real time, and not always in the perfect sense of, what we're used to, like a systematic review or things that are so foundationally kind of ingrained in us to lean towards. But these were, good enough evidence. Some jurisdictions are learning together, and the ability then to reach inwards and also look for other types of evidence that had to emerge in real time as people were experiencing it, and we had to really collect evidence in different ways, sometimes when the data was not even available that we are used to. So I think the main challenge became opportunities. I think in the context of a learning health system type of a process is that we are okay to be uncomfortable with evidence that may not always be the type of standards we are used to. And when I think about health system types of questions and planning and policy discussions, they're always questions that are so contextually driven. I would really equate that to the COVID-19 space. And oftentimes you don't find the exact questions that are so well established in the evidence that you can automatically take something somebody did and plug it into your context. And that's really truly the ability for us to bring evidence in multiple ways, including engaging providers and teams, patients and families and communities, and building the evidence we need as we go. So I would say it's an exciting space that was created, but it's also laying a very strong blueprint to why learning health system can be challenging, but what we learned during COVID-19.
Thanks, Tara. I love that. That's a recurring theme of turning challenges into opportunities. Cindy, did you want to jump in there?
Yeah, so So I think my way to answer this question would be, I really like Dr. Brenda McCormick's work on practice development. And from my perspective, his framework on the good enough evaluation framework really, really stands out for me, and certainly the experience that I've had personally as a registered nurse through the pandemic. For me as a healthcare leader leading a team in the pandemic, and also sharing a little bit of a personal perspective, and think many of us may resonate, having family members in the healthcare system during the COVID-19 pandemic. So that whole idea of a good enough evaluation framework certainly stands out very, very strongly for me, and how it is that we set the interprofessional practice team up on a daily basis of having that as a frame of reference, because we always recognize that things were so rapidly evolving that the information that we had in the moment was the best information we had. And we didn't have the liberty or the ability to not make decisions at that moment. So I just wanted to share that as both an opportunity and a challenge. But I also want to say that it took, unfortunately, this crisis of the pandemic for people to understand how important a learning health system is. And also, I believe that our partnerships in Nova Scotia strengthened because of that, because I feel that our vulnerability together provided us to have really critical conversations, and we didn't all come to the table with the answers. We co-created the solutions. And I am so very, very proud of the many, many things that our teams have been able to do in Nova Scotia. There were many imperfections, but certainly there were many successes. So I just wanted to share that.
Thank you, Cindy. I see Benjamin has a follow-up question or maybe a comment to your responses.
Thank you very much, Adrian. Basically, it's a comment because what I'm listening is quite interesting. And here we have among us MOH officials from several countries, mostly of the Caribbean that I see, and I'm very happy to see the names. And I'm sure they will agree with me that during a particular stage of the pandemic, as in probably most of the world, MOH was completely overwhelmed in terms of responding to COVID-19. So what I see and hear from the responses, flexibility is quite an important component of any learning health system. And so the question is, in this particular context, not in Canada or in highly developed countries, but in Latin America, in the Caribbean and other parts of the world, how to really make national health systems flexible in order to process this data. And I really like the framework presented by Cindy on knowledge to practice, practice to data, data to knowledge, and so on. And that flexibility is probably what we need to have in those national health systems if we want to make them really learning health systems. So that's an additional comment I had. And I completely agree that COVID-19, as a challenge as it was for everyone, it was also a great opportunity, especially in health and human resources for health, because that put us on stage in certain areas that we were not reaching before, and this is including decision making and closeness to the authorities and leaderships. So thank you very much.
I think that that completes the questions that are in the chat. I have a couple of my own that I would love to pose, but I know we're also very close to time. So I think unless there are any further points that folks would like to raise, that Gail, I'll hand it back to you for closing comments today.
Great, thank you. Thank you so much. And here's the first of many webinars go forward. And thank you to PAHO WHO for the commitment to the work that we all do together. And I must say, for that, we are truly grateful. And so we want to engage others in these webinars as we go forward. That will include some really important conversations around, for instance, leadership and governance. We started today to talk more about impact and evaluation. And so evaluating HRH initiatives is going to be really important as we continue to talk about interprofessional education as well as interprofessional collaboration in today's world. We've been talking about this for some time, but I think we're here. I think globally that together we can share some very positive things that are happening as relates to IPE and IPC, but also where are some of those challenges and what are some of those barriers that we need to work together to remove? And oral health, for instance, to name a few. So we also would be interested in your ideas. So thanking PAHO, WHO, for everything that you do for us, and in particular, the leadership that Benjamin, you have brought in the Caribbean. And as many of you in the Caribbean know, I have worked in the Caribbean for quite some time. I am very thankful to what I learn from you each and every day, and how to deal with challenges in a way that always arriving at those innovative solutions through partnerships. Also having the opportunity in the Americas more broadly, and also in the Afro region, it has been a privilege, and we continue to find ways to work together. I also would like to thank our partners here, who you've seen kind of a feel for our partners in the way that we work in Nova Scotia Health, and that is really important to us and our team. So Cindy and Tara and Ruth, definitely, and Janet and Adrian for all of what you've been doing on a day-to-day basis. But behind all of these people are brilliant teams who just make it all happen. And many of them know who they are, and we would like to thank you for this. So from my end, we're thrilled. Thank you so much. And we look forward, we will send out the recording with the updated slides. And Benjamin, anything you would like to say before we say goodbye?
No, just thank everyone, those who participated today, the panelists, Gail and Adrian, Janet for organizing this wonderful event. And I'm looking forward for the next webinar. So we'll keep in touch. Thank you.
Thank you. Thank you so much. And have a
Thank
good
you.
day.
Bye.
Bye, everyone.
Bye-bye.